Folks, I think we'll get started. All right, I know, very early, but it's a good time to connect with folks. So today we are going to have our joint sports medicine and chronic brain injury program grand round. My name is Kadar Hiremath. I am the Associate Director of Ohio State's Chronic Brain Injury Program. So I'm just going to tell you a little bit about what we do, and then we'll get to what you're really here for. So the Chronic Brain Injury Program is a university-wide research center. We started in 2014. We're really focused around brain injuries, but it expands a little bit beyond that, and I'll show you that here in a second. But we're based in the Office of Research. We span the full campus, and the idea is to connect people around our topics of neurotrauma and neurodegenerative disease. We want to essentially enable those teamings, as well as then support the collaborations that result. And we do that by investing in the personnel. We invest in projects, thinking really specifically about interdisciplinary research in that context, and then the environment around the researchers as well as the trainees. Is it going to advance? Let's see. Okay, there we go. Okay, so we're a very large program in terms of the number of people as well as the scope. So really, we're talking about brain injury and not necessarily prevention of brain injury, but thinking, okay, you've had a brain injury. Now what? What's your life going to be like? What are the challenges that you're going to face? And how can we, as a university, and all of the different functions of that university, help to solve those issues? So if you look on the graphic on the right, that's really what's telling about sort of the things that we engage in. So a number of different disease types, a number of different sort of attributes of health and wellness. And then in the research domains, we're really trying to think about this from basic to clinical to systems. It takes a lot of people to do that. So we have 56 core faculty. There's an additional about 60 to 70 faculty that engage with us as affiliates. We're in 7 colleges, and if you include those affiliates, that's 12 colleges. There's 15 Ohio State colleges, and I'm really working on those last 3. There's 18 departments, 37 if you take the full team, and then we have a number of external and internal partners as well. So this is a really well-connected program, and what I hope that this kind of gives you is a sense of, if I'd like to do research, if I'd like to engage in these areas, we're a really good vehicle to do that. So these are the stacks that we operate in. So this is our research areas. So really thinking about like that characterization of disease processes as our fundamental space, really thinking about the technologies and the use case for assessment tools, whether that be a screening or biomonitoring or imaging. And then in the recovery stack, which is I think where we start to really get a little bit more tangible for all of you, really think about what are those individual personalized treatments that we can be developing, the drugs that we can be developing in this space as well, and how do we really streamline rehabilitation. And then we elevate all of that really into that implementation space, thinking about system-wide, statewide a lot, and beyond just the medical, but really thinking about the social and policy environments as well. So why am I telling you this? I want you to get involved. I want you to get engaged. And so these are ways to do this. So on the left is our goals. We really operate on that first one, comprehensive and coordinated plan of care. If it doesn't roll up into something like that, then it's really not doing the job. But then we break these goals down into other different component pieces. And then we've built a program that sort of matches all of those. And so you're here today for that purple one up at the top, CBI Grand Rounds, which is a really, I think, a very impactful piece of our program. And a lot of these programs, as you engage, they could be funding your research. They could be helping you connect with a clinical community or an external patient community. They could be thinking about ways to support the training that you're currently in or doing. And then the outcomes have been really cool. This is a sample set from just last year of, new ways to think about rehab outside the hospital, new ways to image the brain, thinking about really large scale look at rehabilitation practices in inpatient, research training for an international crowd, and then really thinking about new areas as well. So it's not just where do we see concussion, where do we see brain injury, but where are the places that we haven't seen it yet. I think this talk does a little bit to sort of open that up as well. And so that's kind of our goal, is really to expand what the university has been doing in this space. And I hope that you can help us to do that. So that's why we're here, and that's why we wanted to partner with Sports Med. So that's all I have. If you have questions about brain injury, chronic brain injury program, come find me right after. Dr. McCain.
Thank you. Morning, everyone. I'm Dr. McCamey. For those of you who don't know me, I get the pleasure to introduce Dr. Bryant Walrod, who has a special interest and expertise on our topic today, which is MMA and concussion. Dr. Walrod is an associate professor at the Department of Family and Community Medicine, Division of Sports Medicine at Ohio State. He frequently works with endurance athletes, overhead throwing athletes, and combative sport athletes. He has completed several marathons, including the Boston Marathon twice, and he was a former nationally ranked boxer. So he does have a special interest in working with endurance and combative sport athletes to help them compete at their highest level. He is one of the physician leaders for the endurance medicine team, and he heads up the Endurance Medicine Performance Clinic. Dr. Walrod is also the lead for the tactical medicine program. He serves as the physician contact for the ROTC cadets to OSU and the Columbus Division of Police SWAT. He also provides ringside coverage for mixed martial arts and boxing bouts. In addition, he has over 10 years working with professional baseball, and he's currently one of the team physicians for the Columbus Clippers. Finally, Dr. Walrod is a team physician for Ohio State, providing event and training room coverage for numerous Buckeye student athletes. Sorry, my eyes are I might need them. Dr. Walrod, okay, thank you. Dr. Walrod also educates future medical providers through lecturing first-year medical students during their MSK block, serving as the director of the fourth-year medical student sports medicine clerkship. He is also the associate block co-director for the bone and muscle disorder block in the Lead Serve Inspire medical school curriculum. He's an associate program director for OSU's primary care sports medicine fellowship also. And now again, to introduce Dr. Walrod.
Thank you, Kendra. All right. So I'm excited to be here. Obviously, I see a lot of people that I know, which is actually really fun. So I'm not sure how many people are online, but I see a lot of faces I know, which will make this hopefully fun. I have nothing to disclose that is relevant. So as we get started here, I think I kind of want to know our audience. I think part of today is to get an idea of what we can do as a group. So how many people will say are MDs or DOs in this group? I know we don't have a lot of people online, but all right. How many are ATs? How many are PTs? And how many are researchers, clinical researchers? How many are PhDs? Yeah, a nice broad group, which is great. That's exactly what I wanted, kind of see this broad group here of people. I think that's going to be our strength. You know, when I interview people for the College of Medicine, I oftentimes talk about the strength of OSU, and that is one of the strengths is the largeness, the huge group that we have here, and the ability to work as a team. And you see all these different areas of specialty with a similar interest. So I think that's exciting. Hopefully that will open some doors here today. So we're going to go over just a couple of things here. We're going to talk a little bit about concussions, specifically some of the things that we've done at OSU with some of the newer kind of guidelines. And we're going to talk about just some of the basics of ringside medicine. I have a whole other talks on actually covering bouts. If you ever want to talk to me about that, I can help you with that. Then we're going to talk a little bit about some kind of low-hanging fruit that I think we need to really work on, and that's weight loss and hydration in MMA athletes and how that might influence post-concussion symptoms. Then we're going to delve deeper into concussions and post-concussion follow-up. Let me see if I can get this to link, hopefully. So this is the fight that started it all. So I don't know if sound here. So this was 2005. It was Stephen Bonner, Forrest Griffin, not playing. Dang it. Okay. It's playing here, but that's okay. So basically, you can hear it, right? Well, now I gotta stop it. I don't know if I can share the screen. What? Sorry, guys. It was working? Minimize this. Make this small. There we go. Well, we'll just watch it with YouTube. So this is Forrest Griffin and Stephen Bonner. Actually, Stephen Bonner just died, sadly enough. This was this battle. It was the Ultimate Fighter 2005. And you just see the heart and the effort. These warriors fought literally to the end. There was a talk that when the fight started, there were about 2 million people watching it. When the fight ended, there were 3 million people watching it, just because of the intensity and the heart and the grit. made a lot of people fans. Some people might say that it's a brutal, but it made a lot of people fans. Stefan actually lost. Forrest won. They had a rematch, but this is what really kind of launched it. UFC really got popular around 2001, but this really kind of launched, as I said, the kind of the amount of people that tuned in while it was actually happening was incredible. Let's see if I can get back to. I might need your help over here. Get it, there we go. Back. And that's my only link, so we should be good after that. Perfect.
One,
Down.
one
Yep,
more.
that's, yep. Perfect. All right. Thanks. So that was the only link, but really that was when things really kind of took off for the UFC and the MMA world. So make a couple assumptions as always. So we're not going to delve deep into the guidelines. We're going to briefly kind of cover some things, but all of us have a basic understanding of previous guidelines for concussion, understand basic management of concussion. And we're going to limit this to sports concussion because that's kind of where I have the most experience, where my expertise is the greatest. We're not going to talk a lot about chronic, TBI and CTE. So we have updates for concussions. And this was really, when I was getting out of a fellowship, it was really neat to see like the understanding of concussion change. We kind of updated the old Academy of Neurology guidelines from 1997, CAN2 guidelines from 86. This really became when we really started to understand concussions better, started to talk about what we need to do in the post concussion world. And this really kind of, we saw this take place in the NFL, but it really hasn't spilled over too well into combat sports yet. Then they meet every 4 years, new guidelines in 2013 and 2017. So we were all excited for the new ones to come out in 2021. Unfortunately, they didn't. I think COVID kind of slowed that down. They did meet in Amsterdam in 2022. We just came back from AMSM. They said that they're close, but they haven't actually given us an idea of when they're actually coming out. So this is what we have to work with. So we have the old statement from the consensus group. Then the AMSM put out an update in 2019, and ACSM put out an update in 2021. Just to go over some of the clinical things about this, and I want to talk this with respect to MMA. We all know what a concussion is, but you think about the blows. So oftentimes it can be a blow to the head or a blow to the body. You'll see, and I'm going to show you very clearly that one of the goals of MMA is to strike into the head. So oftentimes in MMA, it's going to be from a blow to the head. And we need to factor that in when evaluating these patients. Typically results in the rapid onset of short-lived impairment in memory or neural function that resolves spontaneously, but in some cases, it occurs over minutes to hours. This is another kind of area I think we need to talk about. If you watch MMA, you're going to see that a lot of times they're going to do this cursory exam right after the bout. They're going to shine their light in someone's eyes and maybe let them go. They might only examine the person that lost. I think we're going to miss a lot of potential concussions if we only examine them post-fight. I think you really need to do it to yourself. Examine them post-fight, examine them afterwards in maybe the a training room or the warm-up area, and ideally the next day, because you see that these things are going to change. It may result in some neuropathologic changes that we're going to cover in a bit. I tell our fellows and our students all the time, it's a matter of function, not structure. So we typically don't get imaging. There are some new guidelines from the ARP, which I'll talk about with respect to imaging, maybe pre-fight for a lot of MMA athletes, which I think has some potential. With a graded set of clinical symptoms with or without loss of consciousness. We all know this. I'm not preaching anything new to anybody, but as you'll see, a lot of the MMA guidelines still factor in loss of consciousness as a very important point when they talk about return to activity. I think this is an area for improvement. And some of the newer guidelines, which I think is good, have come up with the idea that it can be explained by other things, drug, alcohol, and I think most often mental kind of comorbid conditions. So we got to think about psychological factors that could contribute to post-concussive symptoms. Again, this is not new to anybody in the room, but I want you to look all the way at the bottom, loss of consciousness. And we're going to talk about this in a little more about where we factor in loss of consciousness with respect to return to activity into combat sports. So we talk about rest, back when the first guidelines came out, rest was one of the key things. And I think rest is still key, can minimize the brain energy demand. There's this energy kind of mismatch that is going on, but not a lot of evidence for rest. So while we do say that rest is still part of the treatments, maybe some sub-symptom threshold exercise should be considered. I remember very clearly doing this, putting people in a room, dark kind of closet thing. That's gone. Now we want these people to get out and kind of be with their friends and activity, try and avoid some of this social isolation, hyper awareness, and their identity. A lot of these people, their identity is their sport or their athletic ability. So being able to get them out. I always tell patients, if you want to go for a walk and it doesn't make your symptoms worse, do it. If you want to do an activity, do it. We got to factor in sports psych a lot when we think about post-concussion follow-up. So we always tell our fellows all the time, if the answer on the test is exercise good, it's good. So you always want to check that box that exercise is good. And you see all the things that exercise can do, and maybe controlled exercise performing at an intensity that doesn't exacerbate symptoms could actually help and maybe decrease some of the persistent post-concussive symptoms. So subthreshold aerobic exercise can actually normalize CV dysfunction, and strict risks after sports related to a concussion can actually slow recovery and increase the probability of prolonged symptoms. These were two small studies. This was 2019, 103 adolescents who were randomly assigned a subsymptom threshold aerobic exercise or a stretching program. Those that did the subsymptom got back to a recovery in just 13 days, where stretching was 17 days. The same individual did a systematic review and came out with a conclusion that subsymptom threshold aerobic exercise is safe and effective for treatment of sports related concussion, as well as athletes with persistent post-concussive symptoms. So do we rest? Maybe a brief period of rest in the acute phase, and then we encourage them to be gradually more active, staying below that symptom exacerbation threshold. It's even been argued that you could tell people to take exercise as medicine for their post-concussion symptoms. Obviously, avoiding vigorous exercise, and the amount and time that we're going to do this is not yet well defined, and we may be hopefully waiting on some of this information on the newest guidelines. But we do want to get them back to normal living. I think this will help to decrease some of the potential comorbid psychologic contributing factors. So we adjusted our thoughts here at OSU a little bit just this past year. We looked at our guidelines. So the same things still kind of hold true. You must be back at full academics. So return to learn greater than return to play. We still use the SCAT-5. We have implemented VOMs this year. You need to be off of any medications, and you have to be fully symptom free. One point on this, we all know these return to play guides. But I think what you need to sometimes talk to your coaches about is that there needs to be one night of sleep between each of these stages. Oftentimes I have them want to come in and maybe in the morning do some light aerobic, and then later that day do some sports specific exercise, and that is not the case. We want to make sure we give one night of sleep in between each of these stages. So we updated our OSU guidelines here, and this is, I think, kind of hopefully in line with the current understanding that light aerobic exercise without resistance training can begin while symptoms are still present, as long as symptoms are not worsening and exercise does not exacerbate their symptoms. And then if light exercise is completed while still symptomatic, then you can jump right to step 2. So I think that's a great thing that we have began to implement. I've talked with some of the ATs, and we're kind of just this year monitoring it to see if it's been a effective change or not. Are most of you guys doing that? I know I had a talk the other day at this. Are most of you guys starting to add some early exercise to your post-concussive? Good. All right. So kind of thinking about roles that you may function when providing sports medicine coverage, primary, secondary, and tertiary. So when we think about this with respect to MMA, the primary role, if you are asked to see an athlete maybe prior to the bout, and this is a area where you can really talk about education. Talk about risk factor reduction. This may be their only touch point to the healthcare system. So you're gonna be able to get these people in, talk to them about hydration, weight loss, post-fight, return to activity. So it's a good time to act as their medical home. You may be asked to fill out a form. Secondary, this would be actually at the event when you're covering the event. Again, I'm not gonna go deep into this because not a lot of us actually cover. I should ask, has anybody ever covered or been ringside for a fight? Nice. All right, good. Okay, I'm curious if you guys have thoughts or questions. And then the last role is really kind of long-term follow-up, things that we're going to do to maybe reduce problems with talking about post-concussion follow-up, post-concussion return to activity, return to sparring, return to a competition. So kind of these three roles that we can function. I think this last role is really where we can all hopefully kind of here work as a group to think about how we can potentially decrease the risk for some of these MMA athletes. A lot of these people are returning very, very soon. If we can start to maybe change rules or laws, I think we can hopefully make it safer. So a lot of programs, a lot of organizations state that, we should not do MMA. It's a barbaric sport and it should be banned. But is that really going to make it a safer sport? There's a lot of interest in it. It's probably just going to go underground and it's going to continue with absolutely zero regulation. And also, it's big business. The UFC just continues to grow. There was a fight last weekend. There's a fight this weekend. Crazy enough, it was sold just for $2 million in 2001. In 2017, it was valued at $2 billion. Just last year at $12 billion. And now the UFC and WWE merged into a $20 billion mega corporation. So it's not going anywhere. And people like it. There's 80,000 combat sports businesses in operation. And as you see, MMA has trumped all the other ones. So the other martial arts are taking a backseat to MMA because of the popularity of it. This is just people that are participating in MMA. About 2.5 million individuals are participating in MMA. That's a huge number. And you see it's kind of stayed steady over the past 5 years. Looking at people that actually compete, we got about 1 million people that compete in MMA. So still a large number of people. Let's compare that with tackle football. So tackle football, as you can imagine, did drop with all the stuff with concussions, but it's starting to kind of remain steady. But now we have twice as many people doing tackle football as we do doing MMA. So think about what we have for tackle football. What do we have in place for high school and college football? We have ATs, we have regulation, we have the NCAA, we have state regulation, we have all these people in place. We have doctors at the games and all that stuff that can help these people post-injury. So with twice the amount of people, we have nobody in place for MMA. Same thing with wrestling. There's 10 times more people doing MMA than are doing wrestling. Again, getting back to high school wrestling, think about what we have in place for high school wrestling. All the same things, ATs, doctors, administration, legislation, all these things that are there to help these athletes to be able to compete on a safer level, and we don't have that in place for MMA. We just had a meeting yesterday. This was pretty interesting, just talking about AT presence. So in the state of Ohio, we have about 75% of schools have access to ATs. That should be up to 100, of course, but we have none of that for MMA. So we're doing a pretty good job of taking care of our high school athletes, but no one is taking care of our MMA athletes. And a lot of that, I think, comes to cost, and that's stuff that we could possibly bring up here, and that would be, who's going to pay for this? Is it going to be the gym owner, the promoter, the state sanctioning body? People make a lot of money off of MMA fights. So if someone's making money, who's going to pay for adequate medical coverage? These are questions that we need to ask. So MMA, just to kind of go over some backgrounds, mixed martial arts, it's a combative sport between two individuals occurring in a ring or a cage with multiple uses of martial arts. So the UFC, as we've covered, is the biggest organization, founded in 1993. They have kind of taken in a bunch of their former rivals. There's other organizations in the US. There's the Bellator MMA. There's a female group called Invitica. And then there's this Fighters League. This is actually Lance Palmer up here on the top left. He was a wrestler here at Ohio State. He's a champion of this league in 2018 and 19. But then the next group are the local venues. I've been up to fights in Marion and some smaller towns in Ohio. And you really wonder, what kind of follow-up are these people having? It's a small town. Maybe some farm people are trying to get out and show how tough they are. And they don't have the follow-up that is in place for the large organizations like UFC. And then there are some international groups as well that are trying to continue to grow the sport. So how can we help? Well, if you're a doctor and you like to cover bouts, you need to get certified. You need to be educated on what it takes to be a ringside doc, know the rules, and really need to talk about two things in specific: weight loss and hydration, and then post-injury concussion follow-up and return to activity. A big issue here and a big kind of gap is that, so think about NFL, NCAA, NHL. These are major organizations that have a jurisdiction across the entire country. The problem with MMA is it's kind of state sanctioned. So we have states that will sanction sports for boxing and MMA. So there can be a lot of variations with respect to activity from state to state. And then how does that change when someone has a fight in Ohio and they go back to Indiana? How does that change? Are they going to be followed with respect to their time off or suspension? So We're always going to be limited when the state commission has control, because we don't have this reaching kind of rule implementation. Why? Also because it's a dangerous sport. This happened in Milwaukee. Actually, it was gone at the time, but I know the doctor who was working a ringside. I was given a talk at this ARP, and he came up to me and was asking me. He was a brand new doc covering MMA. So this is actually kickboxing. At the time, it wasn't regulated in Wisconsin. So this is a fight, and if you watch, I'm not going to click on it because it's pretty tough to watch. But basically, there was horrible gaps in coverage. This individual was having a hard time walking, was stumbling. His corner was literally like keeping him up, and the corner was like hitting him in the face to keep him away. The doc was looking at his phone and ended up in a huge lawsuit and unfortunate loss of life as well. So what can we do? We need to get certified. You need to become educated. The Association of Ringside Physicians is a good option. And here's some of the things you need to consider if you want to be a ringside doc in the state of Ohio. You may be asked to do an exam, maybe at your medical home. You may have an individual who wants to train MMA. This is kind of the pre-fight physical examination form. I think it's fair. I think there's a lot more that we could cover, but it's something, at least it's a start. But this is where I think you need to be the medical home for that MMA athlete and talk about hydration, talk about nutrition, talk about weight loss, talk about concussions. Briefly, we also, for the state of Ohio, recommend negative labs, a dilated eye exam. Sometimes additional imaging is considered. We have additional imaging if maybe you've had a losing record. And in patients that are older, oftentimes you're going to need more of a workup as well, MRI, stress echo, and chest x-ray. Now, if you think about, so all this is done pre-fight, then typically the fight occurs on Saturday, so you have your weigh-ins on Friday. And the weigh-ins when you maybe asked to do a pre-fight physical examination, and you're gonna see, here's our form here. A couple of things to point out on this are size of pupils. Again, I think it's classic to think about someone doing the post-fight, looking at someone's pupils with their little pen light. I think that's fine, but I think that's only a small part of it. So I think we need to say there's a lot more than just looking at the size of the pupils, but it is part, and I think you need to document pre and then a post-fight. The next thing is here, and we talked about this before, if they had a history of LASIK surgery, they're not allowed to fight. And actually, I was looking this up, and it's because there's a flap that happens when they do the LASIK surgery, and it can become dislodged if they get hit in the head. So the old-fashioned, the PRK, you can actually do, and you're allowed to fight. But if you have a young individual who's contemplating MMA, you might need to counsel them that the state of Ohio will not allow you to fight if you've had previous LASIK surgery. Then there's the post-fight examination, again, pupillary size, and maybe a quick part about the exam, and if they won or lost. And then you see the kind of these like cursory kind of time frames. So I don't know why they pick 30, 60, 90 days. I think these are arbitrary numbers that need to be re-examined. I think we know most things don't heal in nice kind of time frames of 1 month, 2 months, or 3 months. So we need to ask ourselves, why do we have these kind of time frames of 30, 60, and 90 days? And then you also will talk about if they need to be seen or followed up by maybe primary care sports medicine, neuro, or ortho if they have a problem. But again, this is for the state, and this is to have a sanctioned competition. This does not follow them back to their gym. Their gym owner might not even know about this. They can go back to their gym, and you're going to see they're going back to their gym very early and starting to fight very early. One nice thing that Ohio has done that some states don't do is they have some weight restrictions. So on the day of the weigh-in, oftentimes you'll see people walk around in a sauna suit, spinning into cups, trying to drop those last couple pounds. And they have now limited how much you can lose within 1 hour of the actual weigh-in. And they also make you weigh in the day of the event, which I think is great. That's definitely a step in the right direction, where if you're less than 155, you can't exceed your previous day's weight by greater than 10 pounds. If you're greater than 155, you can't exceed the previous day's weight by greater than 13 pounds. So these are definitely some steps in the right direction for the state of Ohio. The unified rules of MMA, just to cover, they kind of update these with the guise of kind of fighter safety. I think it isn't bad. So basically 2 contestants that are paired, hopefully equally paired by a promoter and approved by the state. The bouts are typically 3 to 5 rounds. The championship bouts are usually 5 rounds, and each round is 5 minutes in duration. So they are always looking at these to see if they can make the sport safer. And you're going to see with the understanding that there's inherent risk in the sport. There's inherent head trauma as part of the goal of the sport. So they're trying to make it safer while trying to potentially keep the spirit of the sport going. We're going to jump briefly to hydration. I don't know if you all probably are aware of this. In 1997, 3 wrestlers, college wrestlers, died with just in 6 weeks of each other, secondary to excessive weight loss. And this led to changes in legislation and rules for wrestling. And as you've seen, this is actually great. It's still working. It's working well. People are. It hasn't changed the sport. It has, actually, the sport is getting more popular than ever. So now we have weigh-ins the day of, usually an hour or two before competition. So we have led to a lot of less of these major amounts of weight loss. So I think it's something that can be used, can be implemented well. College wrestling has shown that you can do it. The sport still stays popular and flourishes and has interest. Is this still happening in MMA? Unfortunately, it is. We have a lot of excessive weight loss that leads to horrible outcomes. This individual, 2013, he died. He was in a sauna at the time of his weigh-in, admitted to using diuretics, and lost about 20% of his body mass prior to weigh-in. This is 2015 in China. Another individual unfortunately died from complications from his weight cut. Is this still occurring? It still is, unfortunately. In MMA, it's occurring. You'll see most of the studies will have kind of a similar number, around 10% of body mass is lost in the week prior to their competition, and sometimes even 5% just that final 24 hours before. This is, again, when they're employing things like sauna suits and getting into a sauna, diuretics, spitting into a cup. Is it happening in the UFC? Definitely it's happening in the UFC. This person gained 35 pounds from weigh-in to fight day. You'll see some of these people are on the left side of the screen, 20, 25 pounds, 17% of their body weight from weigh-in till a fight day. So it's definitely occurring, and I'd say it's probably more the norm than the exception. Heavyweights would be the exception. You see on the top, that was Stipe, so he only had a 1.1% change. He walks around at his fighting weight. So why is this happening? Well, no one's talking to doctors. No one goes to their family doctor and says, hey, how can I, better lose weight, or how can I hydrate better? They're going to their teammates, social media. Some are seeing dietitians, which is good, but they're not seeking doctor advice. What are they doing? Holding fluids, of course, water loading, which we're going to talk about, saunas, sweatsuits, salt baths, colonics, medications, all very scary methods of weight loss. Another survey in MMA, 76% admitted to using a sauna, 63% rubber plastic suits and training in heated rooms, and 67% did water loading. This is what that is. So water loading is basically going to consume a lot of water for 3 days prior to the competition. Thought this would decrease sodium and increase vasopressin. And then the day before the weigh-in, you just cut out all the fluids, and this will increase your urine production with a weight loss. And this is a graph and a study, small study, 21 grapplers, 10 controlled, 11 were water loaded. The water loading group lost 3.2% of their body mass, whereas the controls lost 2.4%. And here you see that MMA unfortunately leads when you compare it with other combat sports. And this is all secondary to the time of weigh-in. So again, we get to weigh-in 24 hours before, there's an opportunity to gain a lot of weight from the time of weigh-in until the actual bout. You see the greatest amount of weight loss in percent in MMA is 12, and the greatest amount of pounds lost is also 11.5. And they have the highest percent of weight loss in the 24 hours prior to competition, the highest amount of weight regained before weigh-in in competition, and also at 7 days as well. This was a study in the UK. They looked at 3 separate MMA competitions on just 7 athletes, but they measured a couple of things: urine osmolality, weight, food records, weight loss questionnaire, and water intake. And they measured these 6 days prior to competition, at the weigh-in at 32 hours prior, and then 1 hour. And you'll see, just like we saw in the other studies, very large amounts of weight loss. So typically right around that 10% of body mass is lost in the rapid weight loss period, 12% gained in the rapid weight regain period. One athlete lost 10% and gained 20% back. One athlete, he competed at a class that was 3 times higher than his actual weigh-in class. And we saw they were definitely dehydrated, with a significant increase in urine osmolality from baseline to weigh-in, and a decrease from weigh-in to a competition. So then you ask yourselves, what about weight loss? Well, there's an article that came out in 2016 that said that we should ban it. And I think there's something that we should consider there. A lot of states, to be a substance that is illegal, it should satisfy two of these three things: enhance performance, endanger an athlete's health, and violate the spirit of the sport. It could be argued that rapid weight loss and dehydration meets all three of these. The problem is people are doing it, just like doping in cycling and steroids in baseball. If your friend is doing it, you need to keep up with the Joneses. So I think that's where we need to talk about legislation that can possibly improve this, actual rules that are going to be enforced, and talk about reduction in this very dangerous way of weight loss. One championship has done a good job. So they're the one that had an individual diet in 2015. They had banned a weight loss or banned weight cutting by a dehydration. IV hydration is banned. You can't drop a weight class 8 weeks out from competition. And they now weigh in 3 hours prior to your event. The UFC obviously is a big money maker. They like weigh-ins. What if someone goes to a weigh-in and doesn't make weight on the day of the fight? Then the fight has to cancel. So that's why they do it on Friday, because that way they're guaranteed a fight. People pay for these fights. It's a huge, business. They actually extended it from 24 to 36 hours, which I think is going to make it worse. And smaller organizations don't have near the oversight that some of these larger ones. So we talked about the ARP, kind of the lying group with respect to combat sports. And they said in 2014, you should schedule the weigh-ins 24 hours or less prior to competition, certify weights like we have in wrestling, consider establishing a lowest fighting weight like we have in wrestling. And all this data should be stored in a data bank that is able to be accessed across the world, not just in the interstate, because a lot of these people are traveling not just from state to state, but traveling to different countries to fight. And then education sessions to the MMA athletes and the gym owners about proper weight loss methods. So this was my kind of jump to weight loss and concussion. So I think we need to think about weight loss when we start to evaluate somebody with a concussion. We know that hypohydration can impair CNS function and maybe even mimic concussion symptoms. So if somebody comes in and they're fatigued or they're dizzy, is this secondary to the rapid weight cut or secondary to concussion? So potential confounders with respect to post-concussive symptoms, are they due to a blow from concussion, or are they due to their still side effects from rapid weight loss? How often do we see a concussion in MMA? It's a lot. It's hard to really assess, because a lot of the reviews are just video reviews, and they can assume a concussion based upon KO, based upon loss of consciousness, but we don't really have good data. As you see, the range is huge, 85 to 228 per 1,000 athlete exposures. But look at that compared to a football. Even if you stay down to the 85 number, it's 10 times more common than in football. And again, head injuries are the reason why. So a lot of the goal of MMA and combat sports is to strike to the head. So looking at all injuries in MMA, 58 to 78% were head injuries. It's a target. You can target the head when you try to punch somebody. This was just this was an overview from, they examined a video of 285 UFC bouts, and overall injury rate of 51 per 100 athlete exposure. So a pretty high injury rate. And as you see, 2/3 of these were head injuries. This is strikes to the head per minute. Some people are averaging up to 8 strikes in the head per minute. So huge amounts of head trauma that are occurring just within 1 minute. Imagine this in football. Imagine this if you let someone get hit 8 times within 1 minute. I think we'd have rules that would change that. I'm not going to go deep into this, but this is kind of just, we're going to hear me talk a lot about terminology. So a knockout is when a athlete is knocked down and is deemed unconscious or disoriented. A TKO is a technical knockout where the individual is unable to intelligibly defend themselves. And then a TKO is secondary to medical stoppage. You saw that last pick or some last reason we've had to call bounce for. But you'll think about this when you think about, does this patient have a concussion, when you think about KO versus TKO. This is Francis Nagano, and he was a heavyweight champ. Now he's kind of changing camps. They claim that he can punch with a punching power of 96 horsepower. As they said, that's amount, it'd be the equivalent of being hit by a Ford Escort going full power. So this guy's a beast. And as you see, with increased weight comes increased amount of potential head trauma. So these heavyweights, you're going to see a lot of head trauma. Another study that kind of confirms that, you'll see on that graph on the left, With increased weight comes increased amount of head trauma. This also looked at total injuries, and you'll see very similar numbers what we saw before, a total injury rate of 55 out of 100 athlete exposures, and again, head injuries being 2/3 of those. And think about it, if you lost the fight, 83% of those with head injuries lost the fight. And a TKO or a KO to end it, 60% of those had a head injury. This was a really neat study that I found. This was 60 fights, boxing and MMA. They talked about signs and symptoms of concussions with physicians and non-physicians. And what they found was that they averaged 1 concussion for 12.5 minutes of fighting. Now, again, we talked about some of the fights, if they're not a championship, are going to be 15 minutes. The championship are going to be 25. If you look at this bottom left screen here, so this is number of concussions in the fight. It should never be more than 1. So there were some where they were able to evaluate that someone had 8 concussions during a fight. Imagine that happening in a football, someone getting 8 concussions and continuing to go back in there, go back in there. It's just not happening, but it's happening in MMA. But the question is that part of the sport? We have to kind of walk this line, because in football, the goal of the sport is not necessarily for head trauma, to knock someone out, to physically beat someone up, but the goal is to score points and win the game. Or maybe that is the goal of MMA, and that's why they have allowed this. But 8 is way too many. I think you also need to be able to watch these people. It's not even just the concussions. There's this idea of kind of being like dizzy. You're out on your feet. And if you watch a lot of combat sports, you'll see people, they just get rocked and they kind of spin and they kind of walk kind of wobbly. You'll see like this is something that they never make it back from that. So this is where we need to act better and educate our reps better. Once someone is out on their feet and kind of wobbly, we need to stop it. Maybe we could consider, like we have in football, an independent spotter who is watching these fights and saying, hey, I saw that person wobble, we're going to need to call the fight. The other thing that this study showed was that physicians and non-physicians were able to identify a concussion with the same amount of ability. So again, maybe we could potentially get some non-medical personnel who could be spotters, who could say, hey, I saw that person stumble, so maybe we should pull it. I want to talk about 2 areas with respect to concussion I think we need to act, and this is head blows prior to KO and TKO. This is education to our referees, and then post-concussion follow-up, return to practice and sparring. We have a lot of guidance with respect to return to a competition in the state, but not a lot of guidance with respect to return to practice and sparring, and unfortunately, you can see it's happening on a very high rate. This should play. This is not a video, so this is just you want to get an idea of the number of blows before a knockout or TKO. Right there, ref should be stepping in. He missed it. So right now, and then refs kind of watching 1, 2, 3, 4, 5, 6 blows. We'll go to the next one. Oops. So they actually looked at this. So this was KO and TKO head strikes. So before a KO or a knockout, the average time between a strike leading to a KO and the stoppage of the match was 3.5 seconds. During that time, the loser received an average of 2.6 plus or minus 3 strikes and a range of 0 to 20. So someone's getting hit 20 times before being knocked out. 88% of those were to the head. For KOs, it's even worse. The time between the strike and the 30 seconds, the average person got 18.5 strikes with a range of 5 to 46. So 46 strikes in the head before somebody called that bout. 92% of these strikes are to the head. So you might say, well, this is old data. Is this still going on? This is from last Saturday's fight. Here we go. How many shots is this guy taking before they call it? That's 4, 5, 6, 7, 8, 9. Some are not landing, but plenty are that you should be in on this one. 1, 2, 3. Ref is still watching. Hammer fisting, back of the head. So we need to educate our refs on how better to step in. This is another one where I think education, watching a taxi, watching this antalgic gait. He gets rocked here, he's wobbling. He's unable to defend himself here in a minute, just getting pummeled. Again, 12, 14, 16 strikes to the head. Before this big blow here, done. So this is where I think we need to educate our refs on about being able to step and be able to see signs and symptoms that says that a fighter is in distress and unable to intelligibly defend themselves. This was a survey looking at 70 athletes and coaches from combat sports, and they asked them about concussion knowledge and training experience. They asked, do you have anybody who comes to your training sessions? And 70% said, we have nobody. We have no medical experience or exposure at our training sessions. That's not happening in high school. It's not happening in college. It's happening all the time in MMA. And then here's the most scary stuff. They asked you, when did you return to practice? Or how many of you went back to practice within 1 week of being concussed? 41% went back within 1 week. Again, no one is guiding them. And 55% of the pros went back within 1 week. So we need people to intercede and interact quickly to get these people appropriate care before returning to combat. This is this was an internet forum. They got 119 responses. After a concussion, 60% of those returned to competition in just 2 days. And the average days before returning to sparring. So this is sparring. This isn't just practice. This isn't cardio. 5.6 days. This is after a concussion. This is horrible. This shouldn't be happening, and it still continues to happen. This is where we need to work as a group to intervene and potentially get legislation to change this. What's happening? They're not telling us. So this is the survey, and they don't really trust us either. Only 60% said they trust the ringside medical doctor. Why is that? Man, I'm not sure why it is. That's an area that we can potentially act to try to gain their trust. 62% say they had at least one concussion. 57 said they had occurred during competition. 12% had 5 or more concussions. Think about if you have your student athletes, how many are you allowing to continue to compete with 5 or more concussions? 40% returned to training competition on the same day. And I can tell you from college, this was not uncommon. You get rocked, we didn't know what a concussion was too well back then, but you go back and spar the same day. But that was 20 years ago. That shouldn't be happening now. 21% returned earlier than was recommended by their healthcare provider, and 21% hid their symptoms. Why did they do this? Well, a lot of these people love to fight. This is what they do. This is their identity. They want to win. I just from working with these gyms, I trained at this gym, worked out with these guys. A lot of them, this is kind of their home. They're like a second family. A lot of them don't have a lot of good home settings. So this is what they do. They go in and they fight. A lot of them want to make a career out of it, want to be able to pay for their bills by doing this. So they may do dangerous returns with the intent of trying to get back to their sport. This is not to go into too much detail, but this was unique because this was an MMA kind of looking. It was a systematic review of what happens in TBI. They talk about stretching of neurons, glial cells, and blood vessels, resulting in diffuse axonal injury. And the same study showed that MMA fighters experience deficits in reaction. I think that should be enough alone to say reaction is a pretty important part of combat sports. And if you have a deficit in reaction, I think you should certainly not clear them. That will increase the risk for injury as well. They also showed lower self-control and cognitive instability scores. And there were some changes on their MRIs with respect to white matter density deficits. And then again, greater exposure to repetitive head trauma. We've seen some imaging abnormalities, changes in the brain, thalamic and hippocampal volumes. And again, impaired psychomotor speed and reaction time. Important parts of MMA, important parts of combat sports, speed and reaction time. We're letting these people go back. They've also been shown to show increased strain in the corpus callosum and brainstem, and then increased blood-brain barrier disruption. So all this being said, like, who's guiding us? We don't have a lot of guidance. We have the ARP, which again is that group that I talked about, the Association of Ringside Physicians. And this is where I think they kind of walk the line, because they know their role is to cover the sport. The sport isn't going anywhere. Part of the object of the sport is head contact, head trauma. So they have to ask yourself, how much are you going to allow? Are you going to say with the first head blow you have to call it? In most sports, we would. If someone looks concussed, they're going to call it. That's not happening in boxing, not happening in MMA. And I think that's what fans like. They like these big knockouts. They like to see people get hit. So they have to kind of figure out, how can we keep the spirit of the sport as well as keep it safe? I don't think anybody has an answer. And it's still new. It's still young. This is only really 20 years old of sport. We don't have a lot of longer term data. So, but they do state that it should be their concussion guidelines should be more stringent than for non-combat sport counterparts, and that's not happening either. We know that's not happening, as you've seen these people returning to sport much too soon. So this is their kind of statement with respect to concussion and knockouts. So basically they say if you've been knocked out, you probably were concussed, because if you were knocked out and you weren't able to get up before a count of 10, there's some degree of neural impairment that says you were probably concussed. If you didn't have loss of consciousness, but again, we had a hard time getting up before a count of 10, you were likely concussed. And if you did have loss of consciousness, you're definitely concussed. So with a KO, if you look at the ARP, they're going to say you should probably be put into some sort of a concussion protocol, which isn't happening. But this would be a way to say, okay, if they check this box of a knockout, they should probably be filed and not cleared to practice or do anything until seen by a medical doctor. TKOs are a little more complex. Again, this might not all be head trauma. It may be just they're unable to defend themselves. But as you saw in those videos, very clearly taking significant punishment, not fighting back. Is this a concussion? This is where you need to think about maybe some ringside evaluation that may help you to ascertain whether this has been a concussion or not. Again, some of these gaps, we talked about the state to state commission. This is where the problem lies. We don't have the national coverage like we have for the NFL or the NCAA, where we have guidelines that are overreaching. These people will come in from Indiana, fight in Marion, Ohio, be examined, have a couple beers, and then go back home. So they're not being seen, they're not having great follow-up, and that's where we need to kind of intervene and make sure that we have some sort of an overreaching body that will say, we need to keep you guys out of competition for an amount of time until you are safely evaluated. And you're going to see they have, again, these arbitrary numbers of 30 days, 60 days, and 90 days. And I don't know why they have this. This doesn't make a lot of sense with respect to what we know about concussions. Concussions don't heal in 30 days or 60 days or 90 days. This is old data, again, Cantu data, American Academy of Neurology, 1997, 1986. These are old guidelines that need to be relooked at. They do talk about, again, they say if a fighter is exhibiting signs of a concussion during the bout, it should be stopped. I'm not sure if this is happening. So what are signs of a concussion? Gait instability, being wobbly. You saw in those videos, people wobble all the time and they still allow them to compete. So we need to educate our refs. We need to educate the commission that these people are showing signs of a concussion early on. Unfortunately, fights are allowed to continue. And then they have these, again, arbitrary numbers. This is the ARP. So if you had a TKO secondary to blows to the head, you're out of competition and sparring for 30 days. I don't think there's any evidence behind this. I do like the fact that they mentioned sparring, not just a competition, because a lot of the guidelines do only mention a competition. And then they said if you have a KO without loss of consciousness, out of competition sparring for 60 days, again, I don't see the evidence for 60 days. And if you got knocked out with loss of consciousness, you're out of sparring competition for 90 days. So again, not sure the evidence is there. This is where I think we could potentially talk to our legislators, talk to these national groups and say, hey, we need to look at these guidelines because some people are maybe they're being actually held out too long. Maybe 90 days is actually too long. Briefly going on this a little bit more. So all combat sport athletes, including the winners, should be evaluated. I think this is an important point. Oftentimes you'll see if someone get rocked, the ringside doc will go do a quick exam with their pen light and then send them on their way. That's not enough. You need to do an exam immediately post-bout, but then you need to follow them, go into the training room or wherever they warm up and then do an exam, because we also talked about these symptoms can evolve over time. So this really should be seen probably the next day as well. This may lead to changes. Sometimes you only have one doc covering an MMA bout. You're going to need a team of docs. Back when I used to cover, we would have a team of ATs and docs, and we would do all the pre-fight physicals, and we would cover. We'd have a whole kind of plan in place with respect to who's seeing who wins. So I think that's something that needs to be considered. Oddly enough, the ARP says you can participate in non-contact training and conditioning 1 week after sustaining a concussion. So again, I don't see any evidence for that. Why did they choose 1 week? Do we let all of our athletes go back to training 1 week after a concussion? I would say no. You have to look at each person as an individual. So again, they like these numbers that fit into these categories, but it's not evidence-based, and I think it puts the fighter at an unsafe ability to return everybody to training in just 1 week after a concussion. I think that needs to be rethought. They said if someone is still having symptoms, they shouldn't go back to sparring. Kind of similar to what we saw when I covered with respect to our guidelines at OSU and what we follow for the national guidelines, different phases. So phase 1 is kind of return to general fitness. This is light aerobic, kind of kicking up your aerobic activity. Should have 24 hours between each step of these phases. Phase 2 is kind of more sport specific stuff like bag work, shadowing, and boxing drills. Again, 24 hours of sleep between each of these steps. And then phase 3 is good, but I think a big gap here is there's who's following these people through these phases. Is it their gym owner, their promoter, their friend? So who is following them through all of these phases? And then when are they cleared? There's no mention in these guidelines that you need to be cleared by the doctor before going back to sparring. And we saw very clearly most people are not following these guidelines and they're going back to sparring way too soon. So there needs to be some sort of legislation or rule change that will not allow these people to get back into the gym, not even to compete in bout. And looking at this, I actually found this was really cool. This is like a 480-page kind of journal that the UFC is just gathering data. So they have started to look at this, and I think in a good way. I'm not going to go into this in great detail, but this is what they kind of came up with, kind of similar, different stages, different phases, and returning activity. And they do mention that you need medical clearance from a physician before being cleared to return to contact. So I like this. These are guidelines, recommendations. Again, enforcement is the big question here. And then briefly, I want to talk about imaging. I'm not going to go deep into all this because it's just information I thought you might want to have. But maybe we should start to consider some baseline MRIs. We can maybe identify those who are at risk. Maybe they've had some underlying change that we don't know about. But again, who's going to pay for this? A lot of these athletes have no insurance. You know, they come from lower kind of socioeconomic homes. Who's going to pay for this? If you're going to get an MRI, they recommend an MRI, a 1.5 or a 3T. That's the test of choice. If you can't, you should get a CT of the brain with and without contrast. They go through a bunch of things when to consider additional workup. And then they said you should consider repeat brain MRIs if someone's had significant head impact exposure that puts them at risk. And maybe you can also use MRIs to kind of follow people over time. If someone's older, the one study said 35, these guys are saying 40, you should consider a CTA or an MRI of the brain. So when do we do imaging after about? We all kind of know this, but just to cover anything that is a concern. Urgent CT scan of the head without contrast for focal neural deficits, emesis, worsening symptoms. But again, talking about the state of Ohio, the ARP says this should be near a designated level 1 trauma center. So if you're in Marion, are you close to a designated level 1 trauma center? Do you have in-house coverage by neurosurgery? You don't. So you start to ask yourselves, maybe we should think about where we're having these bouts as well to make it safer for the athlete. As far as C-spine imaging, they said this should be made on a case-by-case basis. So that being said, I mean, I'm trying to think about, well, what could we do at the ringside? Like, what could we do to maybe potentially increase our likelihood of diagnosing a concussion? I think it would be an ideal world. These people have a medical home. They see us pre-fight. We do baseline scat. We do baseline bombs like we do here at OSU. But that's not the reality. The reality is people are coming from different states. You're coming in for the day. So there's something that we could possibly do that day ringside, maybe at the ringside with minimal training that could be done at weigh-ins and maybe the time of the event. And could this help us to increase our diagnosis of concussion, and with that lead to better follow-up for those that are concussed? And I think we could possibly have this in the King Dept test. And this has actually been studied in MMA. So it's a pretty good test, a sensitivity of 86% with a specificity of 90%. And the ability to be performed by medical and non-medical personnel is great. So if you come there with your team of people, and you have people that are doing baseline King Dept tests at weigh-in, then they can also do those post-fight to see if there's been any change. It's a pretty good test, rapid, reliable, and sensitive, and any worsening in time from baseline would be indicative of a concussion. And maybe also some of this subconcussive impairment. Maybe they look fine. Maybe they look fine. You talk to them, they look good, but you test this, and then you see that they are positive, then that will trigger them to be held out of competition. We have to have that kind of a structure in place for them to follow up. You guys probably all know this, but this is the King Dept test. Basically, you're going to read numbers from left to right, and you're going to see if there's any kind of decrease from their baseline. They looked at this one specific to MMA, and those that had post-fight scores were worse in those with head trauma and worse in those with loss of consciousness. And again, they saw the median change was increased in those with head trauma and loss of consciousness. And they did another study, which I thought was interesting. 92 MMA athletes, they talked about an event and did this change King Dept testing. And it makes sense to have an event be a KO or a TKO. Then they started to look at choke and submission. I think that's an interesting thing to ask yourself. So, like, why would someone have a worsening King Dept test after a choke or submission? But maybe what led up to that choke. So prior to getting choked, they may have been taking multiple head blows that allowed them to get in a position where someone was able to get them into a choke. So it might not be the actual choke event, but the things that led up to getting them in a spot where they were able to be vulnerable to get choked out. So how can we potentially improve this? Well, let's start with some of the low hanging fruit. So weights. So we need to certify weights. It worked in wrestling. We saw that it worked. It didn't change the character of wrestling, didn't change the interest of wrestling, and it's much safer as a result. But again, financially, this is difficult. Think about the weigh-in for MMA. You have a bunch of friends who are going to watch the MMA bout and they weigh in 1 hour before. Somebody doesn't make weight. How is that going to affect their fan base? We need to have an international database, not just a national database. A lot of these people fight in different countries. We need to be able to follow their medical history, their records, if they've been suspended, and who cleared them and for how long. And again, we got to get back to not just competition, but sparring. We saw in those videos very clearly, blows to head before TKO and KO are something where we need to act. We need to educate our referees to show signs of ataxia, to show signs of unable to defend themselves, not allow 40 or 50 blows prior to a TKO. And then we need a follow-up. We need post-bout follow-up, again, at the ringside, but then we definitely need follow-up in the locker room or the warm-up area. This may, again, need 2 doctors to cover, or a team of medical people. And I think you should have follow-up the next day as well, whether this be at the venue, the office, or the gym. I think this is something that we need to have follow-up. The problem is, again, a lot of these people, especially in small town Ohio, are just leaving, going back to their home states. They don't have this built-in follow-up. Again, there's costs involved, there's manpower, but this is something that needs to happen to make the sport safer. We need to talk about recommendations with respect to return to practice. These people are not getting that post-fight. They're not being told you should not spar, you should not exercise. We need to have them have some sort of built-in follow-up where they can have some guidance with respect to return to practice. And then maybe some gym AT coverage. This would be a great thing. There's a lot of gyms here in Columbus. I asked Adrian, you said you don't have anybody at your gym that covers your practice and stuff like that. I think that's a very scary thing. You know, we have a lot of gyms, and even just here in town, where people are sparring and there's no medical coverage there. Maybe we could consider some AT coverage for these gyms. But again, who's going to pay for that? Who's going to pay for an AT to be present, all these things? Maybe the state should, maybe the promoter, maybe tourism. Think about when the UFC comes to Columbus, millions of dollars are brought into this town because of the sport. Maybe some of that money could be spent to have a medical presence at some of these training sessions. And these antiquated, arbitrary 30, 60-day suspensions need to be reconsidered. This is something that doesn't follow the evidence. We know it isn't true. You know, archaic guidelines, almost now 30 years old, that people are following with respect to 30 days. We need to talk to the ARP and see if they can rethink these time frames. And then improve accessibility and adherence to pre and post-bout imaging. Again, you're seeing there is more of a recommendation to do pre-bout imaging, so then you can follow this to see if there's changes. But again, a lot of time this comes down to cost. Who's going to pay for that? You know, these lives people don't have insurance. It might be hard to get a $2,000 3T MRI covered every year. So we know that MMA will continue to grow. It's a booming business. Again, just merging with the WWE, it's huge. Combat sports are not going anywhere. We need to relook at our evidence-based guidelines for ringside medicine coverage. You know, a lot of these old antiquated days are not up to date. We need to talk to the people that are in charge to see if we can change this. We need more medical presence in training. Again, could you have someone potentially at the training centers when there are sparring sessions going on to make sure first people are okay to spar, and then what happens if someone gets hurt during sparring. And I think the low-hanging fruit, as I talked a little bit about, would be hydration and then post-bout follow-up with respect to concussion. And once we solve this problem, we'll go on to this next topic, which is slap fighting. So you'll see this. This is ripe for improvement. But again, you'll see they almost let him back. Almost made it. He says he's good, shakes his head. Good. And he's done. So that'll be for next year. So, all right. With that, I'll say thank you. Appreciate it. Anybody have questions, especially those that have covered, have interest, anything like that? You want? Yeah, Jim.
That was awesome.
Thanks.
I'm so excited. So that's number one. Number two, what's the normal timeline that people fight? So, you know, you have football games, you know, once a week, so on and so forth. What's the normal timeline that people fight MMA fights?
So I think it depends on the level. So the top level, the pros, the UFC might go every 6 months to a year. The big issue and the concerning is the smaller shows. Like back when I used to cover fights, they were fighting every month without a doubt. Going to small towns in Wisconsin, fighting in like Madison and stuff like that. So that's the big problem, is there wasn't the follow-up. Who knows? And again, the winners might need to be examined too, and then held out. It's assumed the winner didn't have a concussion because they won, but no one's really examining them. So the small towns, the smaller venues, fighting much more quickly.
So maybe one of the things is we could get, you can't fight more than once in 2 months time frame. But then again, they may change their name to go to a different.
Go to
league,
Indiana or
go
go,
to
yep.
state,
Mhm, mhm.
and do that.
That's what, again, I think some, national at a minimum kind of guidance with respect to this card that would kind of follow you wherever you go. Here's your card. You have to take it before you step in the ring. This is my most recent bout. This is who I saw. This is who cleared me and stuff like that. I think that needs to happen. Mhm. Yep. Andrew.
So there's a lot of reasons that this care isn't as good as including the fighters themselves who aren't interested in but as a policy directive, what is the simplest thing to do? Because a lot of this stuff, quite frankly, is peaceful. So the guy who fights in Marion on Friday is making minimum wage.
Right.
He is not going to. So when you think about some of the things that have done absolute best, I don't look at our collegiate sports, I look at our high school sports, mandated a evaluation and a document be signed by a peer provider. They all of a sudden changed the awareness of how much concussion was actually out. How many of our high school and adolescent athletes were all of a sudden showing up in clinics and our numbers could jump. So just curious, when you've been at the policy side of things, where do these people feel about their actually finding a safe venue?
It's very difficult because, again, a lot of these are just a guideline, so that the ARP will, give their guidelines about what we think is best practices, which you can see also are not up to date. But they unfortunately they can just give guidelines. It's the state a commission for boxing and MMA are the ones who kind of set the rules. So that'd be probably our first place to act, would be the state. But then you have to ask yourself, how else can we potentially improve it, throughout the state? And this would be trying to get people to be able to be at these events so you can follow these people. It's difficult. It's a state by state thing, and then money is also a big thing as well. Who's going to pay for it? Is it the state commission? Is it the promoter? Is it the tourism for Columbus? Like, there's a lot that goes on. Marion has none of that, so that's going to be a very difficult thing, but it's going to continue to happen. We need to try and grab some of this low hanging fruit to make it safer. Yep.
So the thing that stands out to me is, as a physician, theoretically participating in this understand what protection is there against the enormous medical legal risk being the guy who said it's fine or not?
Well, so I talked to our state commissioner, Bernie, his first name, and he wanted me to cover events, and we don't have malpractice coverage through OSU to cover things like this. And he said, this quote, "You're fine." He's like, no one's ever sued. And I'm like, I don't buy that. That's not going to hold a candle, So I was told, if we were to cover, you have to get your own rider to cover these events. And back when I used to cover, we had him sign. We had a lawyer kind of write something up, and we signed, basically their life away. This is a dangerous sport. You could die, all that kind of stuff. But again, you can be sued for anything. So I think, I can have the best, concrete kind of consent. It doesn't mean it's going to protect me from being sued. So that's the kind of, it's a really difficult. I had this talk just the other day, and it's difficult because there's such a need, but there's so many barriers to it. Unless we had a way that we could encourage people to want to cover and feel safe that they are protected, people are not going to want to cover. So then we have all these gaps in coverage. So it's unfortunate. I think the state commission is where we have to start. Maybe they are the ones who provide medical malpractice coverage if you're going to cover an event. Monica?
This is more, as far as the athletes go, how accepting, I would assume not very accepting to medical coverage. And is there any way possibly to educate them at the lower levels? Have they seen other athletes like not being able to Like,
Right.
you know, they've had a couple fights and they're out and they're not doing well, you know what I'm saying?
Mhm.
We had better coverage or we had better, you know, is there a way to show the athletes?
Yeah,
Good for you, even though we're gonna tell you, no, you can't compete.
I agree. If we had some awareness, some educational awareness campaigns of maybe a prominent fighter who didn't follow medical advice, and this is how he's able to, like function now. I think that would be definitely telling. You saw from the slides, they don't really trust us, and
Right.
and just knowing these guys, they're not the sharpest tool in the shed, and they're kind of meatheady kind of things, and they've gotten mad at me, like gotten in my face, like gotten upset, like well, you can't compete, and they're in your face, their corners in your face, and you just got to kind of stand your ground. It's hard. It's going to take until again they get educated. I think look how long it took us for a concussion and just general sport, changing from got to tough it out to, hey, I need to take time off because this is best for me in the long term. I think we need to continue to push for these athletes to kind of understand that concept. Anybody else? All right. Well, I can get on to clinic, right? Thanks.